So this is Dr. Munnadas. So
Yes.
nice hearing from you. Sir, I have just a small question,
Yes.
practical one from the clinical point of view. We find patients, many of the stroke patients with non-valvular paroxysmal atrial fibrillation who present to you with, for example, say a root MC infarct, and these patients have are maybe a usual hypertensive heart disease substrate. You find the LA marginally dilated, say about 40 to 45 millimeter in the usual measurements, and patient is in sinus rhythm, and a halter or maybe even a event recorder for 7 days, etc., will not pick up any AFib. But in your heart, you know that this is an embolic episode, and these patients need anticoagulation, and you have to go away with aspirin or another antiplatelet. So there, can echo help us, like because there is no hard data to start an anticoagulation in such patients without a documented LA thrombus or something? But there, can echo novel parameters help us to guide whether we can start anticoagulation?
Well, this is a question which was asked me by the neurologists, and they keep asking me about this. I definitely agree that this is a clinical challenge. Coming to your question, whether we can use any of the novel parameters, right now, there are no standardized approaches in terms of, let's say, for example, LA strain. So is there a cutoff value which says that if it is like this, that should we start anticoagulation where it has been, there's a likelihood of an thrombus forming? No. So I wouldn't use LA strain as such as in terms of the newer techniques. But when you look at the, I would make it a little more simple in terms of just looking at the LA appendage velocity. If the LA appendage velocity is above 50, you know that there is a very low likelihood, and then it is unlikely that it is coming from there. So you can sort of be confident, and it's more of a clinical judgment where you can say that it is unlikely that it has come from the appendage or in terms of the thrombus itself. But if the velocity is low, especially if you have somewhere around 30 or even lesser, then I think you might sort of really consider it in a clinical sort of way, whether you can sort of institute some sort of a prophylactic or in a very clinical sort of way, but no real sort of data to say that this is how it should be. But of course, I would be looking at aortic atheromas. I would be looking at the interatrial septum in terms of any aneurysms. So that is the other side which I would be making sure that I'm not missing it out in those areas.
Thank you, sir.
If there are no more questions, then we'll be going on to the next topic, assessing cardiac function in presence of atrial fibrillation, Dr. Manish Bansal.